Welcome back. In this sketch, we'll continue on our journey through the different valves of the heart with a discussion on an important but rarely seen condition, in the US at least, mitral stenosis. FYI, when we mention MS in the sketch, we mean mitral stenosis, not multiple sclerosis. But I'm sure you already knew that. You're in the cardiology unit after all. Comprenez-vous? Good, because we're heading to France for this one. To the mitral patisserie. Phew, overwhelmed already? Shape up, Boulanger. We're just getting started. Anyways, see that baker's hat he's got in his hand? That's a recurring sketchy symbol for mitral valve, the mitre hat. Our exhausted chef is squeezing his mitre hat to represent mitral stenosis, a narrowing of the mitral valve that causes obstruction to blood flow from the left atrium to the left ventricle. Consequently, the pressure within the left atrium, pulmonary vasculature, and right side of the heart all increase, while the left ventricle remains unaffected. The unique pattern of regions affected by mitral stenosis is reflected in its most common clinical presentations. Speaking of which, let's dive in. As with most other valvular diseases, mitral stenosis is a chronic, progressive process. Most patients are asymptomatic or don't recognize their symptoms until very late in the course of disease, when severe MS is present. When patients do develop symptoms, dyspnea on exertion, represented by our overwhelmed baker blowing out a puff of air, is the most common and often only presenting complaint of mitral stenosis. In MS, the degree of dyspnea is primarily related to the severity of stenosis. Exertional dyspnea is usually the result of elevated left atrial pressure and pulmonary venous hypertension, which leads to reduced lung compliance and vital capacity. The result? Your lungs simply can't expand enough to ventilate adequately when you work out. The increased pulmonary pressures and vascular congestion can lead to hemoptysis, which can manifest in a variety of ways, from blood-tinged sputum to massive frank hemoptysis. Just like this baker, coughing up a mouthful of red frosting right back into the mixing bowl. So that's how the French get their cakes to taste so good. That's smart. Not infrequently, the first presentation of mitral stenosis is an embolic event, most commonly stroke, represented by that splatter of black frosting on this overly eager young baker. Calm down there, Breton. Why are you mixing black frosting in the first place? Anyways, most emboli in MS patients result from clot formation with an enlarged left atrium. Though most emboli in MS end up going to the brain, any end organ can be affected, including the spleen and kidneys. Rarely, patients with mitral stenosis may complain of hoarseness, represented by the horses on that carousel cake, resulting from impingement of the recurrent laryngeal nerve by a super large left atrium. So large, in fact, that it's made this heart all lopsided. Now, does this mean that you should think of MS in every patient coming in complaining of hoarseness? Yeah, no. But rare presentations tend to be the stuff that gets asked on exams and by attendings. So remember Ortner syndrome to look like a rock star on the wards. The symptoms of mitral stenosis can be precipitated or worsened by any situation that increases cardiac output, which increases flow across the mitral valve, or causes tachycardia, which reduces diastolic filling time. These triggers, represented by that huge trigger on the chef's torch, include common events like exercise, pregnancy, and fever. So make sure to ask your patient what makes their symptoms worse. Pretty sure lighting your head on fire isn't helping anyone, mademoiselle. Once you've got mitral stenosis on your differential, it's time to figure out the cause. Nearly all cases of mitral stenosis are caused by rheumatic heart disease, which is why we've made our recurring sketchy symbol for rheumatic heart disease, rhubarb pie, the most popular item on the menu. Because of this, MS is rarely seen in developed countries due to early diagnosis of rheumatic fever and treatment with antibiotics. As you might remember from Sketchy Path, rheumatic heart disease results from autoimmune cross-reactivity of a beta streptococcal antigen to valvular tissue, causing progressive scarring, fibrosis, and fusion of the valve commissures leading to a classic fish mouth appearance. While any valve can be affected by rheumatic heart disease, mitral valve disease is most commonly seen. And that's as much pathology as we'll discuss in this sketch. If you want to know more about the pathogenesis of rheumatic heart disease, check out our rheumatic heart disease Sketchy Path sketch. Mitral stenosis isn't the only consequence of group A strep pharyngitis, however, it's simply the most common and severe sequela of acute rheumatic fever. What is acute rheumatic fever? Glad you asked. It's an inflammatory condition that typically appears 2 to 4 weeks after an episode of group A strep pharyngitis. The major manifestations of acute rheumatic fever can be remembered with the acronym JONES, serendipitously stamped onto these cupcakes here. The J stands for joints, specifically a migratory polyarthritis predominantly involving the large joints such as the knees, ankles, and elbows. Hence the frosting on the elbow of this baker. Little white wine will get that out, buddy. The heart, or Owen Jones, represents acute carditis, which in acute rheumatic fever is classically a pancarditis that can involve the pericardium, myocardium, and, most commonly, endocardium. Migratory polyarthritis and carditis are the two most common manifestations of acute rheumatic fever. But we're not done yet. The N stands for nodules, aka subcutaneous nodules, represented by those nodular candies adorning the N cupcake. Subcutaneous nodules in acute rheumatic fever are firm, painless lesions most commonly found on extensor surfaces like the elbows. The E stands for erythema marginatum, a pink, non-pruritic rash that appears on the trunk and limbs but spares the face. The rash is called erythema marginatum because the lesions have a red margin. Finally, the S stands for Sydenham chorea, a neurologic disorder consisting of abrupt, non-rhythmic, involuntary movements and emotional changes. All 5 major manifestations do not have to be present to make the diagnosis of acute rheumatic fever. A patient only needs to have 2 of the major manifestations, or even 1 if other minor manifestations are present, to be diagnosed with acute rheumatic fever. Since rheumatic fever is predominantly a disease of childhood, we'll cover it in greater detail in Sketchy Peds. Whereas the symptoms of mitral stenosis can be pretty nonspecific, the objective findings can be diagnostic. Let's see what they are. One of the first things to do is feel that pulse. Left atrial enlargement caused by mitral stenosis often results in atrial fibrillation, especially in older patients with MS. Look for an irregularly irregular pulse, kind of like the signal on that TV screen. In severe MS, signs of right-sided heart failure, such as elevated JVP, pitting lower extremity edema, and hepatojugular reflux can be seen. At Sketchy, heart failure is represented by our recurring symbol, the floppy heart balloon. Check out our chronic heart failure sketch for more details on the clinical presentation of heart failure. If you see pinkish purple patches on your patient's cheeks, don't just assume that they went overboard on the blush that morning, or that they're just messy eaters like Braden here. Severe, hemodynamically significant mitral stenosis can cause cutaneous vasoconstriction that manifests itself as discoloration of the cheeks, a phenomenon known as mitral phases. Alright, I'm sure you've been waiting for it. Let's review the classic heart sounds of mitral stenosis. In mitral stenosis, left atrial pressure is elevated, causing the mitral valve leaflets to be widely separated by the onset of systole. As a result, when the left ventricle contracts, it has the effect of slamming the mitral valve shut, producing an extra loud S1, represented by this extra loud sister demanding that she get her favorite cake now. Wonder where she gets it from. Well, question answered. Mitral stenosis is classically associated with an opening snap caused by the abrupt halt as the stiff stenotic valve opens in early diastole. Listen for a high-pitched snapping sound immediately after S2, best heard at the apex. As mitral stenosis progresses and the valve becomes more and more stenotic, the opening snap occurs earlier and earlier. Thus, the shorter the interval between S2 and the opening snap, represented by that impatient second sister pulling on mom's dress, the more severe the stenosis. The classic murmur in MS is described as a low-pitched mid-diastolic rumble best heard at the apex of the heart with the patient in the left lateral decubitus position. To remind you that the murmur of mitral stenosis is diastolic, we've drawn in our recurring Sketchy symbol, the diastolic diamonds adorning the snappy mom's purse. By the end of your physical exam, you should be pretty confident that your patient has mitral stenosis. Let's now take a look at some of the common tests that are ordered for patients with suspected MS. Check out that tablecloth. No, I don't mean how fashionable it clearly is. See those grid lines on it? That's to remind you that an ECG is commonly obtained in patients with mitral stenosis, and done so primarily for one reason: to look for atrial fibrillation. Left atrial enlargement caused by severe mitral stenosis can cause AFib, manifesting as an irregularly irregular rhythm and absence of P waves on ECG. Head on over to our AFib and A-flutter sketch to learn more about the ECG features of AFib. Cinnamon roll. Oh, got distracted for a sec there. What? It's a cinnamon roll. What do you expect me to do? Wait till I'm done recording? Stop. Anyways, the P-shaped center of that cinnamon roll represents the other unique finding in mitral stenosis, P mitrale, a broad, notched P wave caused by left atrial enlargement that's best seen in lead 2. Notched. Guess that bite was helpful after all. If you've been following along with our other valvular disease sketches, this next test should come as no surprise. Transthoracic echocardiogram is, once again, the test of choice for the diagnosis of mitral stenosis. The characteristic findings of MS on echo include thickened, calcified mitral valve leaflets, a fish mouth orifice, like the opening of that poor guy's costume, and often left atrial enlargement. As with other valvular diseases, echocardiography not only establishes the diagnosis, but can also determine the hemodynamic severity and etiology of mitral stenosis. Speaking of which, we've mentioned severe disease a lot, but what does that actually mean? Well, the most common definition of severe MS is a mitral valve area less than 1.5 centimeters squared. Just take a look at that sign. All items 150 or less? Time to stock up on cake. Don't judge me. There are other values that play a role in defining the severity of MS, but valve area is the most helpful and convenient to remember. That about does it for the information you need to diagnose mitral stenosis. But before we move on to the assessment and plan, let's talk differential. When thinking about what other conditions should be on the differential for mitral stenosis, what comes to mind first? Well, if you said heart failure, you're absolutely right. Chronic heart failure classically presents with dyspnea on exertion, which is also the most common presentation of mitral stenosis. To differentiate between the two conditions, take a look at the BMP and the echocardiogram. An abnormally elevated BMP, greater than 400, and findings of left ventricular systolic or diastolic dysfunction on echo are indications that you might be dealing with heart failure rather than MS. It's important to note, however, that valvular disease is itself a cause of heart failure, so the two conditions can occur simultaneously. The other big category of diseases on the differential for chronic dyspnea is obstructive lung disease. Fortunately, differentiating mitral stenosis from obstructive lung disease such as asthma and COPD is relatively straightforward. If the presenting symptoms and signs don't give it away, take a look at spirometry results. Patients with obstructive lung disease will have the classic scooped flow volume loop pattern. Want to learn more about obstructive lung diseases? We have a whole chapter on it in the pulmonology unit. Speaking of which, let's add another condition onto that differential: bronchiectasis. While dyspnea on exertion isn't the classic presentation of bronchiectasis, it can present with dyspnea and hemoptysis, two symptoms that overlap with those of mitral stenosis. If you're deciding between bronchiectasis and mitral stenosis, the initial test of choice should be a chest x-ray. Look for dilated bronchial walls and irregular peripheral opacities to point you towards bronchiectasis. Alright, let's summarize the clinical presentation of mitral stenosis in a sample assessment statement. Miss Miter is a 38-year-old woman presenting with episodic exertional dyspnea over the past 6 months. She immigrated from Vietnam 3 years ago and has not seen a doctor since moving to the US. She has no known past medical history. Physical exam is notable for an irregularly irregular pulse and a grade 2 out of 6 mid-diastolic murmur heard at the apex without radiation. Her ECG is notable for left atrial enlargement and atrial fibrillation. Given Miss Miter's immigration from a country with a high incidence of rheumatic fever, the most likely diagnosis is severe mitral stenosis secondary to rheumatic heart disease. So now that we've made the diagnosis of mitral stenosis, how do we treat it? One of the first things we need to do when mitral stenosis is diagnosed is to make sure we prevent its complications. The biggest of these is arterial embolization, which is why every patient with mitral stenosis and risk factors for thromboembolism, such as AFib, prior embolic events, or a left atrial thrombus on echo, should receive anticoagulation, represented by that bottle of anti-clog solution being used on that leaky sink. The only drugs approved in the US for anticoagulation in patients with AFib caused by valvular disease are the OG warfarin and heparin. That's because newer anticoagulants were only studied in patients with non-valvular AFib. If you want to look like a rock star on the wards, ask your attending if they'd use a direct oral anticoagulant in a patient with valvular heart disease. In addition to anticoagulation, heart rate control, represented by that heart-shaped pocket watch, is also beneficial in patients who have symptoms due to tachycardia. As heart rate increases, the length of diastole decreases, increasing the pressure gradient across the mitral valve and making symptoms worse. The most commonly used therapy for rate control in mitral stenosis are beta blockers. Consider them in patients with MS and AFib with rapid ventricular response or patients with symptoms associated with exercise. At Sketchy, Beta blockers are represented by our recurring symbol, the muted beta trumpet. So, medical therapy is all nice and good, but sooner or later, you gotta go to the source. Like most of the valvular diseases we've reviewed so far, definitive treatment of mitral stenosis is reserved for patients with severe disease and symptoms. Unlike many of the other valvular diseases we've covered, the initial intervention of choice in mitral stenosis isn't straight up valve replacement surgery. Instead, the preferred intervention is non surgical percutaneous mitral balloon commissurotomy, in which balloon catheters are inflated across the mitral valve, splitting open the commissures and cracking that stenotic mitral valve open. To help you remember that balloon commissurotomy is typically performed first, we've drawn in this hot air balloon behind that fancy trumpet player. So French. From what I know of movies. Those are 100% accurate, right? If balloon commissurotomy doesn't work, or if your patient isn't a candidate for it, the next and final step is surgical mitral valve repair or replacement, represented by those scalpel shaped pegs on the miter hat stand. Alright, let's finish up our discussion of mitral stenosis with a brief recap. Mitral stenosis is most commonly caused by rheumatic heart disease, which makes the condition pretty uncommon in the developed world. The most common presenting symptom of MS is exertional dyspnea, but hemoptysis, hoarseness, and systemic thromboembolism are also potential presentations. The classic cardiac exam in mitral stenosis include a loud S1, opening snap, and rumbling mid-diastolic murmur best heard at the apex. Almost every patient with suspected mitral stenosis gets an ECG to look for AFib caused by left atrial enlargement. As with other valvular disorders, transthoracic echo is the diagnostic tool of choice for mitral stenosis. Characteristic findings include calcified valve leaflets and a fish mouth appearance of the mitral valve orifice. The management of mitral stenosis begins with medical therapy. Anticoagulation for patients with risk factors for thromboembolism, like AFib, and beta blockers for patients whose symptoms are related to tachycardia. Definitive therapy, as you might have guessed, requires surgical intervention, with the minimally invasive percutaneous mitral balloon commissurotomy as the initial step, and straight up mitral valve surgery for those who fail or aren't candidates for PMBC. Bon temps. Sadly, our time in Paris is up, but fortunately, that's the last time you'll be hearing of my amazing French accent.